Thanks very much for those. There's really a fascinating discussion on so many topics. We're going to go ahead and keep on rolling with our next panel. So we just spent some time talking about how do we engage physicians, both during their medical student years, training, and afterwards. This panel, led by Dr. Richard Besser, the Chief Medical Correspondent for ABC News, and also I have a soft spot as a pediatrician myself, a trained pediatrician who still sees patients, and somebody who has a great deal of experience in public health as well. We will look to him to help us lead a discussion about how do we engage, educate the broader public, which, to be honest, is also drawing on many of the same tools that we really need to educate clinicians as well. So I will step off and let Dr. Besser go from here.
Well, thanks very much. It's a real privilege to be here at the Brookings and to meet the panel. When I excuse me?
Your mic's not on.
I know they're working it.
Yeah.
When I told friends that I was coming to the Brookings Institute and I was going to be moderating a panel, and I was excited about this because I'm very interested in health policy. I've spent my career in public health, and I said that the session here is on involving physicians in payment and delivery reform, and the panel was going to be on how can we better explain payment and delivery reform to the public and physicians. I think it was about 10 words in that they all got this kind of glazed look in their eyes, and I think that's one of the challenges, in listening to the previous panel about, how do you educate physicians about this and the challenges that physicians face. One of the questions is, do physicians really want to be educated about this? Because if they don't, there's no way they're going to be taking it in. It's a lack of demand, even though there may be a lot of supply of information. And so I think this panel is going to be very interesting because if you think about where physicians are getting information today, they're getting it where the general public is getting information, and that's from the media. And we're really fortunate to have a very talented panel of health and science writers here to help talk us through this. And I'll just introduce them all briefly. To my right, Joanne Kennan is the healthcare editor of Politico. She's covered health policy and politics in Washington since 1994. She's worked at a number of other media outlets. Next to her is Elizabeth Rosenthal, a New York Times senior writer who trained as a medical doctor and is working on a year-long series on healthcare costs and pricing. She's been a reporter correspondent at the New York Times for more than 20 years, covering many different areas. Next to her is Laura Helmuth, is the science and health editor for Slate magazine, and previously was the senior science editor for Smithsonian and a writer for Science magazine news department. And then on the end is Phil Gallowitz, who is senior correspondent at Kaiser Health News and a board member of the Association of Healthcare Journalists. He was with the Palm Beach Post before that. And you'll notice that there are no broadcast or no television journalists here. There's a reason for that. I came to TV about 4 years ago and all excited about how we could use TV to promote public health. But I got to tell you, anytime I would pitch a healthcare policy or Affordable Care Act story, it would get kind of a chuckle. The only way we cover the issue is basically as a political story. Of who won this battle, who won that battle, but nothing in terms of the issues that are involved. You all write to slightly different audiences, but they're all pretty much, I would say, on the higher education spectrum. And so what I want to try and steer us into is a discussion of how the work you do for your audience may help to inform physicians who are part of that audience. And I'll start with you, Joanne. How do you take these policy issues and make them real for your audience?
I think when five of us were talking on the phone, I said that whenever I try to talk about delivery system reform, people always think I'm talking about whether they're going to get their mail on Saturdays. You know, the disconnect. I mean, obviously the last few months we've been writing about the exchanges, Medicaid, the politics. I mean, that's the story right now. But we actually do write about delivery system reform, and we write about you know, a lot of aspects of the healthcare system. And it is really, you know, if you were to hold up the ACA in its printed form and tell people that only 15, 20% of the pages are really about coverage and the rest is about changing our healthcare system, they'd say, nah. I mean, it has not penetrated. It is not, people do not understand. And writing about this is extremely, you know, we get the same, you know, what is delivery system reform? Why should I care? It is a hard topic to penetrate, even within the policy world, although I think there is an increasing level of understanding, but I don't think it's at a critical mass yet.
And I want to encourage all of you, if there's something someone says and you want to jump in, just you can give me a little hand sign or whatever, or you can just jump in. Elizabeth, for you, I mean, do you view making policy real to people part of what you're doing?
Well, definitely, but my series, The Pain Till It Hurts, began because my managing editor wanted me to come cover the ACA. You know, it's once a physician, always a physician. And I said, I don't want to do, you know, this candidate says this candidate says that. It's incredibly complicated. I'm a fan of it, but $70 million for Navigator shows you just how complicated a system it is. And for me, having practiced in an ER, the issue is how to make this personal. I think that's the challenge for everyone. So what I said is I want to do a series about patient costs and what people are seeing on the ground in the office for ordinary procedures. I don't want to focus on the $500,000 cancer treatment because people will read that and say, wow, that's really expensive, but I hope I don't get that cancer. So we've focused on things that everyone could relate to. And I guess one of the things, how I feel that translates to the doctor discussion is, you know, the first thing doctors can do, and I've spoken to a lot of doctor groups about this now, which I think is great, is bring up cost. You know, how many people talk about cost when it comes to healthcare? And maybe you can't be educated in this constantly evolving healthcare reform, but doctors should be able to answer a question from a patient. Okay, you're telling me to get a colonoscopy. How much is that going to cost? Okay, you're telling me to get an MRI. How much is that going to cost? And I know there's a million reasons why doctors say, oh, I can't do that. It depends on X, Y, and Z. Well, you know your office, you know your microenvironment, and I think that's a really important first step, both for our readers, which is why I've focused on this, and for the physician community, because now it's like Voldemort in a doctor's office. You know, you can't talk about what it costs.
So by empowering or educating the patient, they're going to bring these questions to their doctor?
Yeah, they're going to say, and we've gotten, you know, 30,000 responses, so I hate being called traditional media rather than social media on this, for this series, more than Nate Silver during the election, I have to say. So, you know, I think people want to engage, and what people are saying is, I want to be able to ask my doctor, and they say, oh, when I ask my doctor, I get this kind of toxic look, or it's embarrassing. And I think we have to, you know, factor that into our discussion. There was a great op-ed in the New England Journal, I thought, about, you know, making cost talking about cost as a side effect. We have to start doing that.
Laura, what's your approach at Slate as an editor with a lot of say over what stories you're covering in this area?
Yeah, so I edit all kinds of different writers, freelance writers, policy people, MDs, and we find that stories written by experts, written by MDs, do very well. People want to read from an actual doctor what actually happens, and also, you know, we've been lucky. One of the best stories we had, one of the most popular, was actually by Darshak Sanghavi and Kavita Patel, who I think is here too. I think she's running one of the panels. And it used one of just the oldest tropes in magazine journalism, which is a list. And if you think about some of the things you see over and over, almost the cliches of journalism, 10 embarrassing questions, or 5 reasons you should do this, or 6 amazing photographs. I mean, these are really popular, and they work. And you might as well, especially if you're dealing with a really complicated subject, use these sort of they're tricks in a way, but use these things that intrigue people, that will pull them in, that will not be intimidating. And I think especially with this subject, where even if somebody knows a lot about medicine, they may be intimidated by the economics, or if they know the numbers, the genetics is throwing them. We find it's really effective to just be as simple and direct and clever and funny and opinionated as possible, and that's really what seems to grab people much more than the explanatory stories, at least for us.
Phil, who do you see as your audience, and how do you decide, how do you make this real, and how do you decide what you're going to be covering?
Sure. At Kaiser Health News, we sort of write for the consumer. We also write for the health policy community. So the challenge we face is trying to cover both of those audiences, and obviously there's a different knowledge base there. But in many ways, it's bringing it down to the core level. The hard part that we have is it's so complicated. Every time we write a story, we know we have to explain it. Language is so important. We can't get above everybody. I was doing some research recently about, there's been a lot of surveys out how nobody understands the Affordable Care Act, right? All the parts of it, nobody gets it. Then I went back and said, well, how many people even know what Medicare is? And the latest surveys actually show 35% of Americans can't tell you what Medicare is. 45% of Americans can't tell you what Medicaid is. These programs have been around for 48 years, so it's not a fact that they're new. But that reminds us as reporters that there's these things, you can't assume everything. But I think that's what I do. The original question about how do you get people in? I think consumers care about healthcare when you're sick. They care about healthcare when they have to go buy insurance for themselves or their parents. I think doctors care about healthcare and health policy when it hits them, monetarily, I'm going to say in a wallet or a purse, or when they see mandates coming down that will affect how they practice. That's when they care. So when I try to write stories, I try to go out there and write a story, visit somebody, write a story. I wrote a story about bundling payments in Medicare. This could be possibly the most boring story you could write. Yada, yada, yada. I went out to Tulsa, Oklahoma, and I ended up writing an A1 story for USA Today about bundling, because I was able to go into an operating room with an orthopedic surgeon and show how his life was changing, spend time with the patient, and show that even though this bundling thing was well beyond them, they didn't understand it, I could bring it down to their level and show why the care they were getting was going to be different than maybe another patient, because they were in this pilot program that Medicare is putting together. So what I really try to do, and I think what my colleagues try to do, is bring it down to the basic levels. What does it mean for the doctor at the level? What does it mean for the patient? And at the end of the day, try to tell a story. We're storytellers at the end of the day.
I want to really get into that area, because here it's a room and an institution that focuses on policy. And a straight policy conversation can be mind-numbing if it's not what you really love. How do you use stories to make this come alive? And if you can give an example of one that you felt really illustrated a key part of what's going on in health reform.
Well, for Politico, we don't do a lot of real people stories. I mean, I have as a writer elsewhere. I've written for many, many, many outlets. I mean, you name it, I've written for them. So, and I miss, part of me misses being able to go out and talk to patients. At Politico, we really are in the intersection of policy and politics. So rarely will we really, we won't go into a clinical setting very often. So that's sort of less what I'm doing right now. I think that one thing that I encounter is that when you talk to doctors, you expect, you sort of come at them expecting them to know more than, your average American, and they don't. And sometimes when I've been in a situation where I've gone to something like an IHI conference where, there's this thousands of excited early adopters, right? All, the mission, the contagious mission of improving American medicine. And then you come back and you think, we're at the tipping point, and you come back and you just interview somebody or have your own personal interaction with a physician as a patient, and it's the same brick wall. And I think one of the impediments to telling these stories is because even when you try to break through the politics, you've got two really confounding issues. One is it's really, really complicated. it is incredibly complicated. And the second thing is it's been poisoned by the political dialogue. So that when you try to have a discussion about, do we need mammograms, there's all sorts of other cross currents come about, championing women's health versus death panels and rationing. It's very hard to have a conversation, a pure conversation or a pure story that is not laden with all the.
Well, I definitely want to come back to the political context in which this story is unfolding. But going on, an example of how you use stories.
Oh well, my writing this year is completely story based, and it's been really easy. And in the sense of, we started this series with just a little blog post on our well blogs about how difficult it was to get a price for a hip replacement. There was a wonderful medical student actually she's now a medical student. At the time she was a college senior, who called around for a summer research project to 200 hospitals and said, what does it cost? And not surprisingly, very few could answer. And as our little I'm open for business question, I said at the bottom of that story, have you had an experience in healthcare costs that you'd like to share with us? And this post was up for about 2 hours on our well blog, never appeared in the paper, and we got over 500 comments. That set off a kind of discussion, which I would have liked to be more interactive, but it got more interactive as the year went on. And every person in our series is someone who commented on an earlier story. So these are people presenting their medical dilemmas to us, and they're, I felt like I was auditioning people for a movie. For this one, we want someone in California. So I would look for people with asthma in California with insurance. And I think there are many, many stories out there. And, they were all wonderful people. I mean, Michael, the one I always like to tell is my character, Michael Chopin, who's a real person who needed a hip replacement. And he wrote this to me in response to that first blog post. I've been waiting to tell this story to someone for 3 years because it's so frustrating. He had insurance. He was 62. He had a chronic hip problem. He was the best medical consumer on earth. He went to his hospital and got a price, Swedish hospital in Seattle. He went to the orthopedic surgeon and got a price. He even went to the device makers. He researched which device he wanted, went to Stryker and found someone who knew someone who would give him a wholesale price for this device. So you couldn't have asked for a better story. And he added it all up. Again, working guy, insured, but not covered for this. And decided, his retirement savings, he didn't want to blow on a hip replacement. And he found a place in Belgium to get it done, right? So that was a compelling, terrific, wonderful story. But I can tell you within these 30,000 comments now, I have, an abundance of smart, well-intentioned people who are trying hard to make this system work in a system that isn't working for a lot of people. And so I guess the idea is, to me, is that all medicine is really personal. So this system may be very complicated, but in fact, the Affordable Care Act and what it means for you is very specific. And that's why I think we need to talk about it in that way. And it's, it's like one of those 1,000 different stories. The more we tell, the story I'm working on now, which is about chronic diseases, the people I've interviewed so far are a dentist, a pharmacist, an insurance broker, and a retired physician who are really having trouble making this system work. And
you wanted to jump in on that?
Yeah, I agree with everything you said. I think it's somehow easier, for journalists to explain the problems with our system. The real challenge is sometimes explaining the future, what we hope payment reform can be. But I think the way that journalists can best do that, I think we've done this many stories, is before you get into the solutions, talk about the solution is because of this problem. One issue with Medicaid that I just wrote about is this Medicaid private option. It's this experiment Arkansas is thinking of trying. It's getting a lot of headlines. But again, I think it probably goes over the head of 97% of readers because, again, Why should I care? If either I'm on Medicaid or I'm not Medicaid. I think the journalists have an issue to explain the problems. And as you mentioned, keeping it local, keeping it personal. For me, I found it easiest. I get more people my stories grab more attention when I can explain the problem. Like in Palm Beach, we had a huge problem a few years ago. Specialists were no longer wanting to work in the emergency room taking call. They said, too much malpractice risk, not enough money, it's not worth my time. So patients in a large swath of Palm Beach County, 80, 90 miles, were having to travel hours to find an orthopedic surgeon. This is not a third world country, this is West Palm Beach. And we wrote about the problem, but the story was only interesting because we were able to talk about how kids and people were dying because they couldn't find a specialist in West Palm Beach to treat them after they had a stroke. Yes, and those are the kind of stories that get local health leaders to talk about, oh, we have to step in, as opposed to trying to write about the future, about ACOs examples. ACOs is a hot topic, but how can you get doctors and the consumers to care? I think you first have to explain ACOs are a solution to solve this is the problem.
Laura, does Slate use stories in a similar way?
We do, yeah, and especially, like you were saying, you've got the one person who'd spent 3 years waiting to tell this story. Yeah. I think everybody has a story like that in them, either about their own experience, and I know anybody who's in clinical practice has stories about patients that are really memorable. They're the kind of stories you dine out on. Of course, you have to respect confidentiality and all that, but it can be very effective to say, this is what this particular person went through, and also, especially from a doctor's perspective, you basically see so many different people, and you can compare different experiences and see what worked. And that's, like you were saying, solving the problems. This is sort of a kind of an underused trope of medical reporting, of any kind of communication, is the what works story. And those can be very powerful. So if you do see, especially starting now, if you're seeing people who are having better outcomes in whatever way, thanks to the Affordable Care Act, thanks to whatever new reform, that's very powerful, and that's a story that doesn't get told often enough, and that's something you should definitely consider how to share.
Well, I want to get into that. You were saying, Joanne, about the political context. And so stories about this working will tend to run on in media outlets that in some way were supportive of the Affordable Care Act, or at least not totally against it. And stories about the horrible impacts of the Affordable Care Act will run in other media outlets. And people tend to turn to those media outlets with which they agree. Is it only a story in Politico if there's conflict?
No, I've written stories about, obviously right now we are in an era of conflict in capital letters, and that is part of what we write about. But we've written stories about, we have done stories about delivery system or clinical improvement. I've written about the reduction of induced early deliveries. I've written about hospice utilization patterns. I've written about, we've done some things in emergency medicine. So we can do that. We're not going to get the prime placement at the top of the website, but I can do those stories for Politico, and I can do a story that does very well on the Politico home site, sometimes because it'll take off in social media, on a non-political, something that's not people screaming at each other. The last few months and the next few months, we're still going to be heavily in the screaming at each other mode. Yeah. But we do write about other things, and I'm lucky because I sort of have the brief to do both of those things. I'm writing for the general political audience, and I'm also writing for a more, our subscriber service is a more sophisticated provider audience.
Elizabeth?
Yeah, I was just going to say, I think part of the issue for the Affordable Care Act is it's really early. It's really hard to judge anything by what happens in the first few months, even the first few years. And yet, as media, there's always pressure to say, how's it going? How's it going? And, I have a colleague who's been following the rollout. Sure, there are going to be good things that happen, and there are going to be, stumbles along the way. And I don't envy her at all trying to do that, because you can't say as a daily reporter, let's just wait a year and see what happens, And
you'll be looking for a job pretty soon.
It's years, yeah.
Do you see a role for the work you do in trying to move us past some of this polarization? Or is that not really the responsibility of working journalists?
I think at Slate, we definitely use the conflict. And that's one of the levers. You know, in polite conversation, you're not supposed to talk about politics and religion, and that's what we write about all the time, because it's something you can read about and you can get worked up about, and especially if you're, you know, reading among like-minded people, it can be, you know, it gets people worked up, it gets them engaged, gets them excited. So yeah, we use it as a lever. It's not the only one, but you know, if you can say that it's actually a good thing that people will quit their jobs and go do something else because they're no longer, you know, tethered to this horrible job that they hate because they need the insurance. If you can, you know, paint that either as, oh no, it's a job killer, or it's a, you know, it makes you free and independent and, you know, all these other wonderful virtuous things. So it definitely works. You can definitely build a bigger, more engaged, more sharing audience if you do kind of pull out the political points, pull out the opinion, pull out the arguments in ways that, you know, like-minded people will enjoy and agree with.
I'm going to open it up in just a moment to all of you, so please be thinking about your questions. You know, I know in my arena, a story about death panels might get on the air. A story about how do we ration scarce resources and allocate those at end of life would not. Do you experience similar things in terms of how you try and pitch a story to get out there?
I mean, timing is everything, right? I mean, the stories like death panels, yes, 3-4 years ago, yeah, it was page one news. I think if you went today to an editor, hey, let's write a story about death panels in the ACA, I think maybe even Fox News would look at it and say, I'm not sure that's really news today. Again, this whole, the Medicaid private option, again, 2 years ago, nobody cared. All of a sudden now, there's stories on, you know, NPR and NewsHour and Washington Post about it. I think it's all about the timing. You mentioned conflict. One of my best editors at Kaiser Health News, first question she would always ask me in the story, where's the conflict? Couldn't write the story. Where's the conflict? So yes, we're always looking for a conflict. That's what helps tell the story. But I think journalists can get beyond just reporting that, you know, ACA is good, ACA is bad, and just giving the same language back and forth. I think we have an obligation to go out and find the story, not just have people repeating the language to get their words out.
Elizabeth?
Yeah, no, and I think if you're lucky, as I've been, and as many of my colleagues are, to do something longer, you can get into that nuance. I mean, if you have 30 seconds, death panels, or you're writing a headline, death panels works. But, you know, and initially, you know, no one in my series died. No one had a terrible illness. Everyone ended up happy with their medical care. They weren't happy with the system and the pricing of it. So I think the point I was hoping to make with these stories is not just, oh, this is a disaster, but there's a better way. And here's where the money added up in their care. And here, sometimes by looking to Europe, but sometimes by looking to other people in the US, we saw that there are better ways. You know, and I think part of what we as journalists are trying to address is this sense in the US of inevitability, that our system has to be this way, that, you know, it's because we get the best care, or because, you know, we have this you know, our politics is averse to single payer. And I think what I wanted to point out is to open up the possibility that there are other options.
Let's open it up to the audience. The microphone is there. I see a couple hands over on this side. If you could say who you are and what organization you're with, that'd be great.
Sure. I actually have a question from Twitter, from Conway Comments. How do we change the news coverage of healthcare reform from insurance coverage and politics to population health?
To population health?
Correct.
Don't use the term population health.
Yeah, I mean, I have to say, as a public health person, I spent most of my career at the CDC. I had to totally undo what I had learned how to do, because for public health, it's the aggregation of individuals where you get the power and you see clarity and you see solutions. But for TV, you have to undo that and find an individual who represents the topic you're trying to deal with. Someone else want to hit that?
Yeah, We had some success with a series about why life expectancy doubled, and this is a public, a series of public health victories, over long term, the building codes, vaccine, all kinds of delivery systems, but we tried to make it personal by asking readers to share their own stories of what medical intervention had saved their own lives. Would you have died of a burst appendix at age 12, but you didn't? And so there are clever ways, especially with social media, to get people engaged in public health and recognize that, oh yeah, my sister would have died in childbirth if it weren't for modern obstetrics. So there are tricks you can use basically with social media that are kind of, I think, the cutting edge of connecting personal stories with public health and big systems.
I think we do right. I think there's some topics that are consistently covered. I think certainly obesity has been consistently covered. Tobacco, I have written more tobacco stories than I could possibly count. I think that some of the wellness aspects of the Affordable Care Act have been covered in terms of how their incentives and programs in the law. I think if I were to say, let's write a population, as he just said, I mean, that my editors aren't going to get what that means. I think there are some public health and prevention. I think there is in our stories about cost, which we don't go out the same way she does, but we do talk about prevention and the argument about, when does it save money, where does it save money? The CBO won't give you credit for saving money 30 years from now. So we do tackle some of those questions.
I think if you're someone who's pitching one of these population health or policy stories, you need to have in your mind who's the character, who can represent the story, because if you can't, it's really easy to say no.
But I'd be the first to say that. I mean, I was a few years ago we did a series on the diabetes epidemic in South Florida, and we'd put the story off for years. We kept putting it off. It's like there has to be, it's diabetes, but we're not disease of the week reporters like we were 30 years ago. But but then when we went in depth and we talked to a lot of people, we had great photos, showed the problems people are having, why this thing is getting worse and worse. The series got amazing pickup. And what you thought was a story that people had heard all, but what new could you say about diabetes? People were really enthralled with it. But they were enthralled with it not just because I think partly because we were giving the information in a way they could understand and showing how people's lives were being dramatically changed. I mean, as reporters, we were going out there, I'm not sure how it sounds good, but we wanted to find sort of the extreme examples. And unfortunately, they weren't that hard to find. In other words, we were talking, I need somebody who's blind and lost a leg and an arm, or somebody who's lost 2 legs. And these are the issues, but these are the things that make these things really stand out. And so I think that, and hopefully, maybe some people went out and got tested, or maybe somebody went out and their lives changed, or their diet changed, or something, they got some help because this series brought the attention that they hadn't gotten elsewhere.
Question over here.
Hi, Nancy Nielsen, University at Buffalo School of Medicine. 2 questions, basically. The first is triggered by what you've said about people tend to listen to and read what they agree with. So they end up in an echo chamber. And yet when you get them in a room like this, they really do want impartial, nonpartisan evaluation. They want facts, but they don't listen to it. So where do we point people to for the trusted source? The second question has to do with price. Doctors, I'm a physician, doctors do not know any more than patients about price. We've been as insulated for all the reasons that Elizabeth could write about. My question is, do you think that the move toward price transparency, while resisted by some insurers and some out-of-network charge doctors and hospitals, is that really going to change this insulation in terms of what things really cost in medical care?
Who'd like to tackle one of those?
I can.
Okay.
I know in Congress, healthcare is very polarized. I can tell you, I do feel like it's one of those issues that if you polled American people about their health care, they would all say, we need reform. I don't think it's as polarized. It's like, I hope I'm not opening a big can of worms here, assault weapons bans. That, you ask, if you take a poll, you find one thing, but in Congress, it doesn't play out that way. Do I think price transparency is the answer? No, I don't think it's the answer. I think it's a first step. That's a small step. And when people say, this is so complicated, what can we do? I think it's a way to open the conversation about the expense of care, the choices that we have to make, why we default to expensive choices. I think it's a conversation that we need to make part of our national conversation, and there's no reason why it shouldn't start in offices, and I think there's also no reason why it does in every other country. When you want to you go to a French doctor's office, there's a price list.
When you all are writing for stories on health reform, do you ever think that physicians are part of your audience? And if so, how does that play into what you're writing about?
I mean, we actually on our comments mode have a specific place that healthcare providers can comment, and we get tons of comments. And I have to say, there are some, really angry, but also I would say the majority of them are quite, yes, we want to be involved. And so I think that's really heartening too.
I have had two, not so much a Politico, but actually one piece I did for Slate a few years ago. I've had two areas where I've had a lot of feedback from physician readers. And one was when I wrote about malpractice and alternative for malpractice reform, and I wrote a few articles on, disclosed and apologize. It's a lot more than the press usually. It's not just, oh, I'm sorry, don't, so no one sues me. That it's a more complicated, many-month form of arbitration and process. I got a lot of physician feedback, and a lot of it was angry. And at the same time, I've also written a lot about end-of-life care. And that's a situation where I have really been able to combine policy with being in a clinical setting and being in really emotionally powerful clinical settings. I've been in hospice, I've been in an ICU, I've been at dying people's bedsides. And that has provoked a lot of reaction from physicians and arguments from physicians online, with some very defensive, some always feeling like there's a moral obligation to always do the most aggressive thing, and sort of the intensivist versus the hospice doctor. So yeah, I've gotten feedback, not so much about the exchanges in Medicaid, because I'm writing for a slightly different audience right now. But I've watched some pretty interesting online arguments for physician readers.
Phil?
Right, doctors don't seem to get as passionate about the policy as opposed to, as you mentioned, Joanne, the malpractice, medical mistakes issues. I can always recall this one letter I got, it's probably 15, 20 years ago, about a doctor after he read a series I wrote about medical mistakes, and he wrote, if my scalpel were as dangerous as your pen, I would have killed many patients long ago. And he wrote me a letter. He was from Palm Beach, a doctor, but I'd covered the community there for many, many years, and I tried to write the good and the bad and the good. Didn't show I was there for many years, and over time, I think it was some built-up respect. But I can understand there's a sensitivity there. Now the question is, how can you translate getting doctors to be as passionate about that when you write about those? I can understand why it's sensitive issues. As reporters, we see a need to bring out medical errors to light, not just to shame somebody, but just this is what's happening in our community. Something that shouldn't happen happened. But how can you take that same passion to bring it toward health policy, health costs? On the one health cost issue I got that I wrote about, where a lot of doctors wrote to me, we wrote a couple stories after an insurance company for the first time published the rates about what they were paying doctors for outpatient procedures. And this was Cigna probably 6 or 7 years ago. I thought, oh, that's interesting. And they released the data, even though I wasn't a Cigna member, they released the data to me. And I wrote about this. And doctors said, oh, that's interesting. Why am I getting paid less than the doctor across the street? That's what they cared most about. And the impact it had was that doctors were trying to negotiate better rates, because now they knew what the competitors were getting. And I think the insurer questioned really if they really wanted to release those rates.
Other questions? You have one here in the front.
Good morning, Geraldine McGinty. I'm a radiologist, and Elizabeth, really have enjoyed your articles in the Times, but you also wrote about the fact that we're seeing a lot of physicians transition to working for hospitals, and I think I totally think that having those discussions with our patients is our responsibility as physicians, but apropos of the health affairs articles, where even orthopedic surgeons who wanted to get to know what the price of the devices couldn't find that out because of their hospital's confidentiality agreements, I think really important for us to understand some of the barriers we're up against.
I think, and this is why I really enjoyed hearing from a lot of physicians, and this was a big issue we heard about, because in my kind of blocking out of this health reform issue, there are a lot of doctors out there who are really, really upset about trying to do the right thing for their patients and not being able to. Now, you know, I hope, I haven't worked in a hospital in 20 years, but I was salaried when I did work at a hospital. I hope that the doctors have some leverage on their hospitals to say, you know, we have to hear, we need to know what these prices are. We want to see what your bundled charge is. You know, and I have heard from groups, you know, the Medical Society of Wisconsin has been very active in helping some of the orthopedists there find out about pricing. It's helped the cardiologists manage bundled pricing and get and kind of turn the screws, because at some level, patients have no control over what hospitals do. Physicians are their labor force. So, you know, my message to physicians, and I don't think, you know, this, the physician organizations on the whole have focused on, in their lobbying, on payment. That's not what I hear from physicians in comments they're concerned about. They're concerned about, how come I can't get the price of this? Why do I feel like the workhorse here? Why are there 7,000 administrators who are being paid 3 times what I am? And I think physician organizations and physicians have to focus more on that to help the reform move along.
If you look ahead 1 year from now, what will this story be when it comes to the Affordable Care Act or healthcare reform?
I think it's going to be a tale of two nations kind of thing. I mean, the haves and the have-nots. It's not going to be one story. You know, it's not, wow, this thing worked great, or wow, this didn't work at all. It's going to be multiple stories. It's going to be people in Texas and Florida where the expansion is much less than their cousins and their family up in New York or in New Jersey. So I think we're going to see this dichotomy. The question is, when we see this big shift about people have been helped in some parts of the country but not others, the question will be is, how does that affect the politics? How does that affect change?
Is it mainly a political story at that point?
No. I think it's a political story, but it's also a public health story. It's a consumer health story, because some uninsured are better off elsewhere in different places. But of course, I preface that by saying that's the country we live in now.
Yeah.
If you before the Affordable Care Act, if you were on Medicaid, you were a whole lot better off in New York City than you were in Miami Beach.
Yeah.
So is life going to be really dramatically different? But I think we passed this big health reform that I think even people don't understand the details thought, oh, we passed health reform, we've dealt with the huge healthcare problems in this country. I think a year from now, more and more people are going to realize that no, this didn't really solve a lot of the problems for me.
And we're running low on time. Laura, what do you think the story will be at Slate?
Yeah, at Slate specifically. I mean, I think in general, it will continue to be a very political story, and I think it will be increasingly divorced from the facts. And that's the trend that we've seen. It's not reversing, it's not even slowing. And that makes it absolutely urgent that people who do understand the facts and actually feel bound by them are willing to be as aggressive, as good at telling stories, as good at using lists, as good at writing headlines, and fighting the same battle to get people's attention, to be the signal in the noise, and basically using the tricks that people who are not bound by facts will use. Yeah. And not be ashamed to do that. And
Elizabeth, will you still be telling these stories in a year?
I think I will, and I think it will accelerate. I think the Affordable Care Act will probably fall into the background because many people will have care and it will become assumed. You can't take that away. But I think what we're seeing in the ACA and also in private insurance policies is people are experiencing greater out-of-pocket expenses in all of them. And so I think patients and physicians are going to become much more price sensitive and cost aware. And I think that part is good.
Joanne?
Quickly, I think some of the coverage fights about ACA, it's going to depend on what happens in the Senate in 2014. But I think there's another story that's for the physician audience and the clinical. We've always looked at SGR, the doc fix, as a payment, an end of the year payment fight where, how long do I have to stand in the hallway while they look for the money? But it has become a reform story now because it is now a tool for paying doctors differently with the transition period, moving away from fee-for-service. I don't think that's yet really appreciated. I don't know what it's going to look like or whether they do it this year because they still have to find the money. But I think that sort of on the mega public story, it's going to be very political. I think for the payment reform issues, that has the potential to be an underappreciated force for changing payment and delivery system.
Well,
Quality.
I want to thank our panelists. Those of you who are physicians or interested in physician education, this is where I think physicians are going to be getting their information for a long time, if not for forever. It's the media that is reaching folks. And thank you all for your time, and thanks for your attention. Don't forget to take your microphone.